Hi there, I'm Lucy Macdonald, physiotherapist. Welcome back to my virtual clinic. Today, I've got a very special guest, Mr. Alexander Montgomery from Schoen Clinic. He is a leading spinal surgeon, and he's here to talk to us about disc problems and how they can cause back pain, and most importantly, how those disc problems can be treated. And I also have my helpful assistant here, Bob, who is a plastic model of the spine. So, first of all, to introduce you to Alexander Montgomery. Monty, as you are known to so many of us, would you like to give a bit more information, a bit more of your background?
Yeah, so as you said, I'm a spinal surgeon, but actually most of the people we see don't need surgery. Most people go to physio, as you know. Some people need osteopathy, some people go to Pilates, but a lot of the people come to us because things haven't worked out so far. They would like a scan and they just want reassurance. And, you know, there's the odd person that needs an injection, and the odd, occasionally people need surgery as well. So that's what I do. I work in the NHS and private, and here at the Schoen Clinic in London.
Brilliant, thank you. And if you want to get in touch with Mr. Montgomery, then please do email him, montgomery@schoenclinic.co.uk. So just that second part is Schoen, which is spelled SCHOEN -clinic.co.uk. And if you want to get in touch with me, it's lucy@octopusclinic.com. So first of all, Monty, could you explain to us how common disc problems are in the lower back?
So yeah, I mean, obviously disc problems are very common. So first of all, I'd say is that having a disc that wears down or a bulging disc is literally the most common thing you get apart from the cold. I mean, it's a time-related change. It's part of life. It happens. Most of the time it's not painful, but sometimes it is painful. Sometimes you get pain from within the disc. Sometimes it pushes on the nerve and you get what people call sciatica. So you get leg pain if it's in your lower back. So it's incredibly common. So the biggest thing to realize is that having a bulging disc or worn down disc is just a normal thing that happens with the passage of time, and sometimes it's painful. And that's why they come to people like you and me.
And I think that's a really, really important thing to note, is that so many people who are given the diagnosis of a disc problem often really worry, perhaps sometimes they go online and are immediately drawn to the minority of very severe cases. But as you say, it's an incredibly common condition, and people can fully recover, and the vast majority do. Probably before we go a bit further, you and I know what we're talking about when we're talking about the discs in the lower back, but there'll be plenty of people watching this who won't know what we're talking about. So could you talk us through what the discs are in the back, please?
Yeah, sure. I mean, if I could ask you first, just to show where the disc is on the so if you point out the bone there, Lucy, what we call the vertebra, so that's the L5 vertebra, that's L4, and the bit in between, which you can see, is the disc. So what I say to my patients is the disc is like a pillow. It's a cushion. It's basically a cushion or a pillow. It's a shock absorber, and it's so that when you bend, when you stand, when you move, there is something that cushions your bones and joints. The difference between a pillow and the disc is that, unfortunately, with time, the disc does wear down. What does that mean? Well, it dehydrates, it loses the proteins that make it bouncy, and it gets a bit harder. And when it gets a bit harder, it can bulge. And actually, most people, even with that, don't have any symptoms. It's only when you get to a stage where the disc is painful or it pushes on the nerve that it becomes a problem. So essentially, it's basically a shock absorber. It's a pillow.
Thank you, thank you. And what are the different injuries to a disc? How can a disc cause pain? You've referred to it a bit already, but if you could just explain that a bit more, that'd be great.
Yeah, so you can get a tear in the disc. I mean, that's sometimes difficult to diagnose on MRI scan. That might be an incident, but more often than not, it's with the passage of time as it wears down, the nerves, the pain nerves start growing into the disc, and so it becomes sensitive. And so that's why a lot of discs are not painful, and some of them are painful because you get the nerve endings growing in. and then sometimes it can react with the bone and cause what we call modic change, which is kind of inflammation or reaction around the bone. Most of the time that settles on its own, or with physio, that 80% of the time it goes within 6 weeks, about 90% within 3 months. And then for the last 10%, of half of those will get better at some point in the next 9 to 12 months. But unfortunately, there's about sort of 5 to 7% of people who need some kind of input from people like myself. Yeah. So most people obviously get better.
And that comes on to the next thing. So as you say, the vast majority will get better with time and with physio and exercise. And we won't dwell on that today. If those of you watching would like to know more about physio for disc problems, then please do go and watch the back pain playlist on the YouTube channel. There's a section there, and in there I go through exercises, advice, how to manage it from a physio perspective. So please do go and check that out. But as we have Mr. Alexander Montgomery here today, it would be great to hear if you are in that smaller percentage of people that do need further intervention, what kind of thing are you looking at that point?
So obviously you start with minimal, and there are steroid injections which are used around the world. And there's a misconception about steroid injections that they're just temporary pain relief. But actually the first thing about a steroid injection is to see if reducing the inflammation and swelling around the disc and the nerve and reducing pain levels enables the physio and rehab process to work better. If you take that away and they don't have that pain inhibition and the muscles are activating potentially a bit better, will the physio work better? And often about 70 to 80% of the time it does work better if it hasn't worked before. And you can do that a few times and continue that cycle for, whatever, 4, 6, 8 months, and hope that over that time people get better range of movement, they get better stability, better postural endurance, and are able to offload the area of the spine that's kind of causing the problem.
Absolutely, and you can see me nodding enthusiastically there in the background, because I've certainly seen that on in hundreds of cases over my years, and obviously the research backs that up too. One of the things that I'm often asked by patients and friends with back pain is with disc issues is how do you get the disc to go back in? Is that possible? And if so, how can one do that? Can you clunk it back in?
I can push it back in surgery, but it'll just come back out again.
Surgery, yeah.
So it depends what the problem is. So if it's a disc, there's a disc bulge, which is a slight bulge, and there's a prolapse where it completely comes out. Pushing it back in has no merit whatsoever. It'll just come back out again. A disc, unfortunately, is a one-off structure. If it prolapses, it loses its structure, integrity, the bounciness, the cushion, the amazing physiology it has to carry out its function, which unfortunately goes with time. And so we've tried in the past, not me personally, people have tried in the past to put it back in and stitch it. It causes all sorts of problems and it doesn't serve its function. So unfortunately, it can go back in, but it'll come back out again. And so
likewise, have you ever met? And likewise, have you ever met a physio or other kind of therapist that's been able to push the disc back in?
No, you can't push it back in. The only person that can push it back in is a surgeon, but he's got it in his hands. You can't
absolutely,
push
but
it
I
back
think
in
that's often again.
Have I met anyone? Yes, yeah, I've met a few people that thought they could, but
that claim to, yeah, and I think that's really important. Yeah. That's why I'm kind of pushing the topic. Is that from my experience, people want to know how physio or injections are going to push the disc back in, and as you say, it's not possible and not required, most importantly, to get rid of their symptoms. So I think that's why I was kind of pushing down that route. So
I mean, just on that topic, I mean, people say to me, they'll sit here and they say, oh, well, physio or injection isn't resolving the problem of the bulging disc or the prolapse disc. Two things I'll say about that. 90% of the time, your body will get rid of any prolapse. So it'll come in and it'll eat it up with the inflammatory chemicals, and that's why you get inflammation. Secondly, most people with a bulging disc or prolapse disc have no symptoms. So if you can be like them, that's our goal.
Yeah,
it's not
absolutely.
pushing it back in. Yeah,
absolutely. Yeah. So we have tried physio, we've tried injection, still unfortunately things are not progressing. What are the options after that?
So there's a big difference in whether you have back pain or leg pain or both. Most people have sciatica or leg pain where you get compression of the nerve. And if you've tried 1 or 2 injections and a whole bunch of physio, then you've got the option of an operation called a discectomy or decompression, a microdiscectomy, where you just shave that portion of the disc. So you make a small incision. My incision is about that big in the lower back. And you go through the muscle, you sometimes shave a bit of bone, and you take that portion of disc away that's pressing on the nerve. And results of that are about 90% success rate in terms of relieving the symptoms. The question is, when do you do it? And that's a complex question. There are very good studies. The sports trial, as in SPORT, capital letters, is probably the best study in terms of outcomes and when you should operate, when to not. That's just a study, generic study across a lot of people. Of course, you've got a patient in front of you who may be 65, 70, maybe 18, he may be 30, he may be an Olympic athlete, and I get all of those. So you have to tailor that crossroad of when you make that decision according to the patient, and that's where your experience in terms of applying the research comes in. Mm-hmm. So for instance, we know roughly that for your average person, say it was you or me, that at 6 months, you know, the chances is going to get better if it's still there despite injections of physiotherapy is not zero, but it's reasonably slim. But actually your outcomes from surgery are slowly going to drop from that moment, because you and I still want to be active and we want to get back to all the things we do. So for us, that's a good time to come in. For someone who's 75 who walks to the shops, then I'd probably wait 9 to 12 months. An elite athlete won't wait 6 months. He'll probably want it done at 4 months. So it's kind of individual, if that makes sense.
What are the risks of surgery? I don't want to dwell on this too much, but what are the risks?
Yeah, so again, there's a lot of myth behind spinal surgery, and that's historical because it's changed a lot in the last 15 years. So the risk of nerve damage, which is the one everyone worries about, there's no, for lower lumbar microdiscectomy, there's no risk of paralysis. I've never met anyone that has had that complication. I certainly haven't. So you're talking about nerve damage, so nerves going to individual muscle groups. So something that might give you, say,
these little guys.
Yeah.
And the ones inside the spine, which we can't
so
see very much.
If you show the L45 and the L5S1 disc,
these guys coming out. Oh, I can't really open it, unfortunately, Monty.
Yeah. But the disc is around the bottom there. If you show the bottom, those are the most commonly affected discs. And they're the nerves really to the calf and foot. And so even if you had nerve damage, you wouldn't get paralysis, you wouldn't get weakness in your hip or knee. It would be in their foot, basically. So the chance of that is about 1 in 400, 1 in 500. So I've personally never had that complication from microdiscectomy, but it's around that. The chance of damaging other nerves, like to the knee or the hip or to even the bowel and bladder, which is the most important thing, is less than 1 in 500. So that's the one everyone wants to know about. There's about a 5% chance of getting spinal fluid leak, which gives you a headache and can slow the wound healing. But other than that, it's the same risk for any operation, like, you know, a 3% risk of infection and so on. But really, you know, I did one yesterday morning, and by yesterday evening, this morning, you want to go home. So in general, it's a pretty quick procedure that should be able to get you out of hospital pretty quickly.
Brilliant. And I would say as well is that it very much depends on the surgeon, and I know you're a very modest guy, but I know that is a significant factor too, and certainly not just from the literature but from my personal experience as well. I would certainly trust you with my spine, Monty, and I wouldn't say that for all surgeons. So if anyone who's watching this and you have gone through all the routes that we've described and you would like to get in touch with Mr. Montgomery, then please do email him Montgomery at clinic.co.uk, but I'll put it in the comments at the bottom of this video anyway, so you can get it properly there. Okay, I think that's probably a really good note to end on. Oh, actually, just to say one more thing. If anyone's worried, there are certain cases where surgery, I know we haven't covered this already in this session, but there are certain cases where surgery might be indicated more quickly. If you're worried about your back pain and you have other symptoms, please do go onto the video where I explain when back pain is an emergency. So that's the title of the video. Please do go and watch that, where I talk through the things that would mean that you'd need to go and have emergency treatment. And now I would just like to say thank you so much for joining me in my virtual clinic, Mr. Alexander Montgomery. It's been an absolute pleasure, and I'm sure that all of the viewers have found that incredibly useful. So thank you for giving up your time today. We all very much appreciate it.
Thanks, Lucy. It's great.
No worries, no worries.
Bye.
Okay, so please don't forget to subscribe, press that big red subscribe key, and until the next time, let me know what you would like me to do a video on next. Bye.